Thank you, Manuela. Well, thank you very much. It's my pleasure to discuss with you how we should select patients for the combination of an immune checkpoint, a VEGF inhibitor in first line for metastatic kidney cancer. So this is an educational session. So these are my learning objectives. First, to highlight where the combination of checkpoint inhibitor plus VEGF TKI stands now in our treatment algorithm. Second, on which basis do we have these new guidelines, new algorithm? And lastly, what are the limitations or the uncertainties that are around this data that we should all be aware of? So last year at ESMO, we had these guidelines presented at that time based on the CheckMate 214 data that Camilo just presented, changing our treatment standard in patients with intermediate and poor risk disease, with Nivo-EP becoming the new standard. Over the last year, guidelines have again changed. And these are the updated EAU guidelines. And as you can see, a combination of checkpoint inhibitor plus VEGF TKI, namely axitinib plus pembrolizumab, is now a standard of care in first line, irrespective of the IMDC classification. It is of importance to stress that last week in Europe, CHMP adopted a positive opinion for avelumab plus axitinib based on PFS benefit as in first-line treatment over sunitinib. So these data come from 2 randomized studies, and I put the 3 phase 3, which reported on the approach of combining both a checkpoint inhibitor plus a VEGF or VEGFR TKI inhibitor. These 3 studies have reported over the last year, and 3 manuscripts have been fully published. For the eMotion 151, which, as you will see, and I will expand on that, was not integrated in the guidelines. For the avelumab plus axitinib, I've just mentioned, had a positive CHMP opinion. And with pembrolizumab plus axitinib, which is now standard of care in first line. So if you think again about the guidelines I've shown you, or the algorithm, you could think, well, this is simple. There is a one-size-fits-all. All risk group can be treated the same way. And I will build this rationale on 5 different points. One is that checkpoint inhibitor plus VEGF TKI demonstrated the highest overall response, the highest overall survival benefit over active agent, and this is plus PAB, the key study, which demonstrated a ratio of 0.53. Second point, both checkpoint inhibitor plus VEGF TKI together demonstrated the higher response rate in an unselected patient population. And I put on the same slide the response rate for the Keynote 426 study, moving from 35% with sunitinib to 59% with the combination, and the Javelin Renal 101 study, moving from 25% with sunitinib to 51% for the combination. So if you think about those 2 studies in the context of the CheckMate 214, the dual approach of VEGF TKI plus immune checkpoint provide a response rate above 50% in an unselected patient population. What about PFS? Both VEGF TKI plus IO study demonstrated PFS benefit over active agent sunitinib, and this is also on the slide highlighting the fact that the benefit for the axitinib plus avelumab combination is being seen across the different IMDC risk group, favorable, intermediate, and poor risk group, with all significant hazard ratio. There is a similar trend observed in the Keynote study. However, the number of events in the favorable risk group needs to be closely followed up with more data. Fourth point, we heard about PD-L1 and the challenge of properly selecting our patient. I want to stress here that 2 studies which had PD-L1 positive population as the primary endpoint population not only demonstrated benefit in this subset of patients driven by the biomarker, but also in the intention to treat population. And this is the avelumab plus axitinib study, which demonstrated a median PFS of 13.8 months in the PD-L1 positive population, as well as in the overall population. Now I'm coming to eMotion 151 to make the same point. In this study, primary endpoint population was PD-L1 positive patient, and looking at PFS, the study did demonstrate a benefit both in the PD-L1 positive driven population as well as in the intention to treat. Nevertheless, with the caveats that Camilo just made, there is strong difference between one trial and another with the way we selected the so-called PD-L1 positive population, different biomarker, different way of assessing this biomarker. Fifth and last point, it looks like the addition of VEGF-TKI plus immune checkpoint seems to be manageable in a way that most of those toxicities are the ones that we were used to handle with TKI. There are few overlapping toxicities, among which maybe liver toxicity or GI toxicities needs specific management, but it's very likely that we will learn and be able to conduct those those combination of VEGF plus checkpoint inhibitor. So that was the shortest way of seeing things, and maybe a bit too simplistic. Because there are many caveats to this approach, and once again I will highlight 5 of them. The first one is the lack of follow-up. This is the keynote data, which were reported with a median follow-up of 12.8 months, showing this very impressive hazard ratio. But what do we know about short follow-up? That it can be misleading. This is the eMotion 151 study, which initially reported, based on PFS benefit, PD-L1 positive population I've shown you, as well as ITT, but also suggested a trend in terms of overall survival in the biomarker-based population in the first report, as well maybe in the intention to treat population. And that was reported with a median follow-up of 18 months at the time of first analysis for the PFS. These are the curves with longer follow-up. And this is the longer follow-up with the 24 months interim analysis for overall survival. And unfortunately, the initial signal was not confirmed with a longer follow-up. And that's the reason why this combination has not been integrated into our guidelines. Second point, are all checkpoint inhibitor VEGF combination equivalent or not? On that slide, if I hide the nivo-EP because the bottom line is to compare those two VEGF-TKI plus IO strategy, we do see a signal that is significant for overall survival for the axitinib plus pembrolizumab combination, while we're still pending more follow-up for the axitinib plus avelumab. Although, as I've said, PFS was hit and CHMP positive. Do we expect new combination to come into the game? There are at least 2 trials which still have sunitinib as the reference arm that needs to be read out. The first one is the pembrolizumab plus lenvatinib combination in CLEAR study, and the other one is nivolumab plus cabozantinib. And if you think about those 2 trials, the TKI that are involved have a more broad spectrum than the axitinib that was reported until now. So the safety of those trials will be of importance. What do we know about the best TKI we should combine with? So we had data phase 1, phase 3 for axitinib-based combination, which clearly highlight that axitinib is a potent VEGF TKI that we can combine with either PD-1 pembrolizumab or PD-L1 avelumab. What other data do we have? I didn't put the studies with less than 10 patients. However, I put here the lenvatinib plus pembrolizumab study, for which we will have a poster discussion on Monday during the immunotherapy track, so pay attention to the program, which really reported a strong response rate of 64%, including a vast majority of patients that were pretreated with a PD-1 inhibitor. So I think this is worth importance to follow this other combination. What about tivozanib in combination? These are phase 1 data, but very likely that in terms of safety, this agent could be worth following closely what will be the next steps. So Camilo made the point of CR, and I didn't put the 11 versus 5% because you've seen that. I think there is a lot of noise around CR, and why is that? Because this is what we want to achieve for our patient, and this is the patient expectations. But there are also scientific rationale for us to be willing to achieve deep response. And it has been established with TKI and now with the combination nivo-EP that depth of response is associated with longer overall survival. And so therefore, we aim at having the deepest response rate and, if possible, complete response in our patient. And there is a poster on this point in the focusing on this analysis in the CheckMate 214 study. The second thing, and once again we bridge with melanoma field, is that CR or near CR offers us the opportunity to discontinue treatment. And we've seen that we're evolving in terms of endpoints, and that time to subsequent therapy may be a highly relevant endpoint instead of just treatment duration, given that some of our patients may have treatment discontinuation due to long-term benefit or maybe withdrew because of toxicity but did not require subsequent treatment. And there's a lot of work ongoing to better define what is the new endpoint we should integrate in our studies to assess that point. And of course, if we discontinue treatment, we believe that we will reduce toxicity, especially in the long-term exposure of our treatment. So, getting to the fourth point, safety in the long run. What do we know with TKI plus immune checkpoint? If we look at the keynote cohort study, we do know that there was a need to discontinue one of the drug within the combination in about 25% of the patient. Both drugs had to be discontinued only in less than 10% of the patient, but obviously there has been a need to withdraw one or the other of the drug within the combination. And I really feel that at this time, with a follow-up that's around 1 year, we need to have more insight on long-term exposure, because it's likely that we will not have combination of the two drugs in the long run. What about subsequent therapy? So here the question is, if we use our both drugs in first line, our both approach, VEGF and immune checkpoint, what is going to be left afterwards? I mean, the vast majority of the room are oncologists, and you treat other tumor types, you treat germ cell tumor, you've been treating many kinds of cancer. You do know that what we want to achieve, we want to provide the best option in first line. And this is something we should have in mind, and not necessarily thinking what will be left in my second line or third line available. As I've shown you, increased response rate may be and is associated with OS benefit. We also believe that there may be a role, if we use early on immune checkpoint, to maybe impact the tumor kinetic itself by triggering an immune response. On the other hand, we could also state that we are selecting some clone that will turn out to be resistant. I feel that we don't have much data to support one or the other in the context of RCC. What we know is that VEGF-TKI remains active after VEGF-TKI, because this is what we've been doing for a decade. We also know that VEGF-TKI works after immune checkpoint, and we've seen those data. So it's very likely that we can still use VEGF-TKI after a combination of immune checkpoint plus VEGF inhibitor. Nevertheless, I strongly urge everyone involved in drug development to test new options in those patients who failed the combination, and new regimens are currently being screened with new targets. So I will conclude over the fact that the question about checkpoint inhibitor plus VEGF is, are we really having a synergic effect here? Is it a myth or is it a reality? And shall we discuss sequence or combination as we've just heard? So there is a biological rationale for going towards the two targets at the same time. There is also sequential biopsy taken from the emotion program, which clearly highlighted that we're able to trigger an immune infiltrate following exposure to a TKI, or here bevacizumab VEGF inhibition. However, I feel we don't have many data right now to support the synergy, except for the very potent hazard ratio we've seen in the keynote study. We have some argument that actually plays against the sequence, and one of them is a very recent work conducted by Victor Grunwald that is presented at this ESMO in a poster session. That's a Nivo switch study where patients were started with a TKI, and for which, after a short course of priming, switched to nivolumab. And although these are small numbers and difficult to accrue studies, I think this did not pan out to show a clear signal of synergy or the interest of priming with the TKI. There could be another approach, which would be not switching, but adding. And we have data here, but for the combination of immune checkpoint. And this is a Titan study that will be presented as oral presentation, for which patients start with nivolumab single agent, and in those that are not achieving partial response, adding ipilimumab. And in this study, as you will see, there is a clear signal that you can enhance the response with the addition of ipilimumab in first line in patients that are not achieving great response with nivolumab single agent. So could this rescue strategy of adding be declined with VEGF TKI? We don't have the data yet, but this is certainly something we would like to look at. So to conclude, I think that VEGF TKI plus immune checkpoint inhibitor is now standard of care in first line. Namely, axitinib plus pembrolizumab demonstrated overall survival benefit, and axitinib plus avelumab is approved or pending approval shortly in Europe, approved in the US, and OS benefit is pending. New combinations are going to arrive. I've shown you the 9ER. However, I really feel that as physician, what we now want to see is OS benefit and strong OS benefit. So we've raised the bar. I've said that last year, and I keep saying it. I really feel that we need to raise the expectation. We don't have long-term safety for the combination of VEGF inhibition plus immune checkpoint. It's likely that in routine, there will be a trend to withdraw one or the other drug in the combination in case of toxicity. And we don't know if this will impact the overall survival benefit that we've seen. And so we will need to be able to generate real-world data to assess this. Finally, until we're able to achieve this goal of CR, it's likely that we will keep on testing new combination and maybe move towards triplets. There is obviously a need to define the optimal strategy, especially in the VEGF plus immune checkpoint failure setting. And as you've seen, I haven't said a word on biomarker, except to say that PD-L1 positive PFS was also true in ITT. So it means there is a huge field here to improve our patient selection. And there are trials now ongoing which prospectively assess a biomarker-based strategy. With that, I would like to thank you for your attention.